Very good evening to you all, and on behalf of the Indian Dental Association Chandigarh State Branch and the International College of Dentists Section 6, I extend a very warm welcome to this webinar series on dentistry during COVID-19. While this is the fourth webinar in this series, and today we are here to talk about the evolving strategies for clinical orthodontic management during the acute phase of the COVID-19 pandemic. Before we begin, I want to extend a very warm welcome to our guests from across the India and also from abroad. And we have many participants today from countries, namely Bangladesh, Sri Lanka, Nepal, Afghanistan, some participants from Peru, some from Albania, and some from Canada, from Toronto and British Columbia. So I extend a very warm welcome to all these participants, and this is time to welcome the guest speaker for the day, Professor Sanjay Suri, and the esteemed moderator, Dr. S.P. Agarwal. And I now connect you to Dr. R.P. Gupta, who is the President of Indian Dental Association Chandigarh State Branch, as well the President of International College of Dentists, Section 6, R.P. Gupta.
Thank you, Dr. R.P. Gupta. Sir, good evening and welcome to everyone in today's webinar by Indian Dental Association, Chandigarh State Branch and International College of Dentists, Section 6, comprising India, Sri Lanka and Nepal. It is a fourth webinar of our series, and our focus in all the webinars is on some of critical aspects of different dental specialties and SARS-CoV-2 virus. We have covered endodontics, dental prosthetics, oral surgery. Today we want to bring the most updated current information about the coronavirus disease 2019 on orthodontics, contingency management and provision of emergency urgent treatment, considering the fact there are millions of patients around the world. It is important that orthodontists and dental professionals think globally and act locally to minimize the risk of transmitting the virus in their clinical settings. It is our pleasure to extend a cheerful welcome to Dr. S.P. Agarwal, moderator of the webinar. He is the former Vice President of Indian Dental Association Headquarters and former President of Indian Dental Association Delhi State Branch, and is a distinguished orthodontist and Director of Delhi-based Green Park Dental Institute and Research Center. His center is approved by International Quality Control Organization and has been certified as ISO 9001 and ISO 14000. He had a rare privilege of working with Brainmark, the father of implantology, in Sydney in 1994. Dr. S. Agarwal is a super implantologist of New Delhi, full of warm and hospitable personality. Sir, we are all proud of you. We are delighted to have you here at a short notice, that too out of your busy schedule. Thank you so much, Dr. Agarwal. We welcome and acknowledge the presence of both his sons of Dr. S.P. Agarwal, Dr. Ankur Agarwal, an orthodontist, and his wife MBA, and Dr. Anuj Agarwal, an oral surgeon. His wife is endodontist, and Dr. Mrs. Agarwal and both his sons' family. They are the persons behind the success of Dr. S.P. Agarwal. It is our pleasure to extend a warm welcome to Dr. Sanjay Suri, Professor and Director of Graduate Orthodontics at the Faculty of Dentistry, University of Toronto, Director of the Burlington Growth Center, and Staff Orthodontist at the Hospital of the Sick Children, Toronto. He is an alumnus of PGI. He is a very brilliant record during his graduation and post-graduation by winning in both the gold medal in both the graduate as well as in the postgraduate examination. He is a high-value academician, researcher, and also having a number of publications in national and international journals of repute. He is par excellence clinician in caring the orthodontic patients. Dear sir, we convey our gratitude for accepting our invitation. Thank you so much. I will narrate here that he has just published a paper on the subject he is going to speak, and I have got the copy of that journal. And only in April he has published that paper, which we are going to listen to now face to face. Thank you so much, Dr. Sir.
Thank you very much, Dr. Gupta. Thank you.
Very nice. We are honored with the presence of viewers, including the orthodontists, dental professionals. We are obliged to each and everyone for participating in this webinar. After attending the webinar, you will become aware that informed that it is imperative for the orthodontist to think wider aspect to minimize the risk of transmitting SARS-CoV-2 in the dental operatory. And I'm certain after this presentation, we all become aware that treatment advice should be delivered remotely first, and wherever possible and necessary, in-person treatment can be performed in well-planned dental clinic with the necessary precaution and infection prevention and control protocol. We will suggest to all of you, be regular with the CD program, enhance your knowledge and believe in yourself. Success shall automatically come in the end. We would like to convey our heartfelt thanks to each and everyone. Jai Hind. I just want to add about that we are having this fourth webinar, and we are all because of my secretary, Dr. Arpit. He is a fellow of our International College of Dentists also, and he is assistant professor in the Department of Oral Health Sciences, PGI Chandigarh, representing from the Dental Public Health faculty. And he is the very hardworking, intellectual, and he knows how to get the work done. I am really proud of you, Mr. Arpit. So nice. Thank you so much.
Thank you, sir. Thank you so much for a very nice beginning. And with this, taking the program ahead, I would like to invite Dr. Gautam Munjal, who is a very senior dentist, and he is an acclaimed orthodontist. And I would invite Dr. Munjal to please introduce the moderator of the day, Dr. S.P. Agarwal. Dr. Munjal, please.
Good evening, everyone, and greetings of the day from the different parts of world. It's a pleasure to introduce our Sutradhar of the evening, our moderator, Dr. S.P. Agarwal, whom I have been knowing since 1987.
Sir, sorry for the interruption. I think Dr. R.P. Gupta has already introduced me, sir.
Sir, I will just say a few words in this, that you are one of the self-made person, a fellow orthodontist, and a very successful practitioner. Dr. Agarwal, about Dr. Agarwal, Dr. RP has already explained all the things, but on this Father's Day, I would like to add that he's a doting father of 2 boys who both are dental surgeons and are part of his team, with daughter-in-laws and wife, and his wife and 2 daughter-in-laws also being dental surgeon to the part of team. So he is I'll say, a complete man, a good orthodontist. And with this, I would request our moderator of the day, Dr. Agarwal, to introduce our speaker of the day. Thank you, and welcome, Dr. Agarwal.
Thank you, Dr. R.P. Gupta, Dr. Munjal, and Dr. Arpit for inviting me to moderate this session. First of all, Dr. Suri, great. I heard a lot about you. I was talking yesterday also with one of my friend's son there, who is known to you and partner in this article in Angle Orthodont, the banner article also. And he talked very high of you. Sir, I know at this time of pandemic, in India, we are passing through a very, very bad phase. How to start, when to start, not to start, and the everyday cases in Delhi, especially Mumbai, they are increasing like anything. Yesterday, we had about 3,600. So how to start it? And especially in orthodontics, because running patients for 1 year, every day, me and my elder son is orthodontist, we get the call, sir, something is broken, something in this. So Dr. Suri, you have been introduced by Dr. R.P. Gupta with your thing, but I was just going through your detailed biodata. And I think you have everything, whatever a dentist can think. All fellowship of American College of Dentists, fellowship of this, from Edinburgh, and you got even the award of Professor Prem Prakash, who was my examiner at one time at Lucknow. I'm from KGMC Lucknow. Sir, I won't take much time because our audience is waiting to listen to you. We will be discussing many things in between, sir. I welcome, sir, Dr. Suri to our audience, sir. We welcome you all, sir. Thank you, sir. Hand over to Dr. Suri.
Very, very kind words of introduction, Dr. Agarwal, and to Dr. Gupta and Dr. Arpit for this very nice introduction and the invitation to speak to your astute group. And you're all doing an excellent amount of service to the community in bringing a number of thoughts across the country and from abroad to serve in the community and invest it into the population that we primarily are responsible to care for. It's a real honor to present a session and discuss this topic with you in the presence of our esteemed moderator, Dr. S.P. Agarwal, very renowned figure in our field in both dentistry and orthodontics. And I have the unique pleasure that this session is also being attended and graced by my teachers. Dr. Treja is there, Dr. S.P. Singh is there. I saw other names of my teachers that have taught me in my undergraduate years as well. Dr. Lal's name came up, and many others that I've had the privilege to learn from. So it's indeed a real pleasure to be able to discuss some thoughts with you in regards to COVID-19 and orthodontics. So with that, I will go into the discussion. The purpose of today's discussion is to look at evolving strategies for clinical orthodontic management during the acute stage of the COVID-19 pandemic. As we go along, I'll share with you as to why I thought of discussing more so the acute stage of the COVID-19 pandemic as we invest your time for the next hour or so in this session. So the broad framework of this talk is going to be to discuss the COVID-19 pandemic, then discuss some implications of the COVID-19 pandemic on the delivery of oral and orthodontic care. And then we'll focus on orthodontic management during the COVID-19 pandemic and trying to keep thoughts more so for the acute phase of the pandemic, which our beloved motherland is going through at this stage. So I'll try to keep it more relevant to the discussion which is pertinent to our community in our motherland. So what have we learned from some of the previous pandemics is important to consider as we look at the current one. So the four main ones which are very well documented and all related to similar contagions or similar ways of transmission were one, of course, the most significant one which had the greatest loss of life, unfortunately, was the Spanish flu of the turn of the century. And then we had the Asian flu in the late 1950s, followed by the Hong Kong flu in the late 1960s. And then we had the other flus as they come along. So what is important to, I'm not going to go much into the history here, but the important thing to know is that when you look at all these flus, you see that the number of mortalities that have gone through have actually decreased over a period of time, which is related to the fact that we as a human race have invested a lot in science and technology and medicine, and we were able to develop strategies. It also depends a lot upon the virulence of the organisms that were causing it and how the population was able to understand the implications of what was required of the community. to prevent the outbreaks and the spreads in the local and therefore in the global scenarios. So this is just the influenza pandemics. There have been other serious epidemics which I will not cover. But what was known from some of these pandemics which have led to a lot of thought process and helps us to prepare for the next ones are that there's a imperative concept that we must always be concerned about. And that is, and you've heard it many, many times, I'm sure other speakers would have discussed it, but as we go into this talk, I just want you to just spend a few moments to think about this. We've all talked about the flattening of the curve. This reflects that we want to do everything possible to try and contain the spread of the virus and mitigate it as far as possible. So if we take due precautions of distancing, of stopping the spread from one person to the other and therefore to the nth person exponentially or from a series, but if we do that, we will be able to mitigate the amount of what is so-called the peak of the virus. So this is the peak that you're seeing. And with due precautions being placed, every community, every population is able to reduce that peak to an extent. Of course, it also depends upon the virulence of the virus itself and how severe it is. But you are able to take due precautions and be able to reduce that. In the meantime, we as healthcare workers and people in the hospitals where we are involved with the ones that are saving lives and making sure that people that need the life support are being provided that, those healthcare capacities are increased by national investment and local hospital investments, and that is increased while the virus spread is decreased, and that's the principle of mitigation. If that doesn't happen for several reasons, whether they are lack of information, lack of investment, or lack of due attention being paid because individuals may not take it seriously and think of it as a common flu. But if you do that, you know that viruses do also come in several stages. They don't come once, and you may have several of these peaks. Some of them could be smaller, some of them could be more balanced out as things go on. But you usually see an initial surge, and then if you have not taken due course to resolve it or to contain it, you may have greater resurgence and greater peaks down the road. And this is an important thing to remember across the world, because we are going through the first peak and some places are starting to see second peaks. But it is quite expected that this virus that we're currently dealing with will also have several of these peaks, and resurgences will be there. And it's important that we have built capacity and we are able to reduce the further peaks, so that if the first one is reduced, the further ones can be also expected to be contained because of not the virus per se alone, which may get attenuated or may get lose its virulence to some extent, but it's also because of the practices that have been put in place after learning from history as well as taking due precautions. So it's very important to keep these aspects in mind, especially when you look at how rapidly this particular virus has spread in the last 3 to 4 months. So to recapitulate, you've all discussed this in several other sessions, but just to recapitulate, the SARS-CoV-2 is a part of the beta coronavirus genera. It is a lipid bilayer enveloped non-segmented positive sense RNA virus. So that's the lipid, it's encased within that lipid sheath. It's a spherical virus, and all these little projections that you have seen this figure probably 100,000 times by now, but those are it's a spherical virus, and the surface appears crown-like because of the spiked glycoprotein projections. The main thing for us to remember as orthodontists or as dentists is that the most potent way that this virus easily spreads is through droplets from the nose and from the mouth. So the droplets from the nasorespiratory tracts, and especially when we look at what are the points of entry or exit, it's the nose and mouth are very potent regions where the virus has a chance to spread from. So the routes of transmission of this virus are respiratory tract via droplets, respiratory secretions, so cough and sneeze, direct contact entering mucous membrane of the mouth, the nose and the eyes. The virus has been found in blood, saliva, and in fecal swabs. There is potential transmission through respiration. It's still controversial. There's data that keeps coming from both sides, but there is a potential that it may be transmitted through respiration. So that's these theories on one side are trying to be resolved and debunked. Others think that that is still a potent way of transmission depending upon the viral load. So it's important to consider that. And then what is becoming increasingly known is that asymptomatic individuals or those that are within the viral incubation period may also be able to transmit the virus. When you look at the numbers that are playing out in India especially, we can always go into controversy and find enough papers that seem to indicate that this might not be the fact. But when you look at the numbers, if you had to err on one side, I would take the hit and say we got to err on the side of being more protected. So we have to consider the fact that there's increasing data becoming available about asymptomatic spread of the virus, and therefore we must take due precautions that when we enact our day-to-day work, we are taking all the steps necessary to mitigate the spread of the virus in our settings. Who are the people that are most at risk? So individuals pretty much at all ages are susceptible to being infected, but advanced age, people who are 65 years of age and older, especially that group of our community, is at greater risk of developing more serious viral disease. The presence of comorbidities in individuals of any age can also make them more at risk of getting infected with this virus. This includes some which are documented over here. More are coming to light as the experience with this virus continues on. Chronic lung disease, moderate to severe asthma, heart disease with complications, diabetes, hypertension, renal failure, liver disease, and people that are immunocompromised. Another factor that is important is that those people that have had close contact with individuals diagnosed with COVID-19 are at more risk of developing the disease as well. So COVID-19, as you would all recall, is the disease that occurs from the infection with the SARS-CoV-2 virus. So when you look at the virus and the disease pattern, we don't start to show symptoms right away. The usual time period that people will start to be exposed to the virus and then the virus incubates, and the average time that it takes is almost about a week, 3 to 7 days. The latent period is defined as the time from the exposure to the time that the person becomes infectious. That could happen early on during that phase. We don't know the exact phase, but this could be in this first 2 weeks' time, the person will likely become contagious to cause the disease spread. So some of these facts we need to remember when we are dealing with every person that we come in contact with, and especially as well with our patients that we are caring for. The exact contagious period still remains exactly unknown at this point. The symptomatic period is when the person that's been infected with the virus will start to show symptoms of the COVID-19 disease. And then people will go either in the direction of improvement, which is the vast majority, or they will worsen. But for those that have improved, they will walk out of the disease after its course and they will start to convalesce. Are they still contagious during that period? Generally, this period is considered to be where there is greater degree of contagiousness. But as the person has convalesced, then the chances of contagiousness have been shown to be less important, less decreased. Do we have an exact time point? Not clear at this moment. The science is still coming out on that aspect. Patients have been defined as being able to leave home isolation when they are recovering from the virus or when they have convalesced, when they present with the following: somebody having normal temperature for more than 3 days, resolved respiratory symptoms, and at least 2 negative tests that have been shown to be negative more than taken 2 days apart, or taken at least more than 24 hours apart. There have been further guidelines that have come on board, and I won't go into greater detail of them because they discuss about asymptomatic patients as well and test-based strategies. But this is a broad consensus framework that we should keep in mind, that one, the contagious period exactly is not known. The period of the virus incubation is somewhat known in this region. 3 to 7 days is considered to be average for incubation. The first 14 days is still considered to be very important when you look at the life cycle of this disease. The clinical manifestations range from a complete lack of symptoms. We're finding more and more of that literature now in the publications, that there is a vast majority of the human race that may never have shown any symptoms and may have already been exposed to this virus. And could those people have caused the spread of the virus? This is all coming out on a daily basis. If you read the papers that are being published even between yesterday afternoon and today, you'll find more information on some of these aspects. But there are many people that are asymptomatic with severe and other people that will develop very severe complications that lead to as much as multi-organ dysfunction, septic shock, and systematic failure. When you look at some studies, and this is an earlier one, but this came from China and had a good large sample size of many, almost 100,000 people. I think it was 80,000 people or so. So what they found was that people with mild symptoms were about 81%. And people with severe symptoms were about 15%. And those that had critical symptoms that needed to be given ventilation life support was about 4%. These figures vary across different population groups. There are studies that have shown that people with mild symptoms may be as much as 90%. Many people are asymptomatic. So when you add that to the category, you know that there is a large portion of the human race that may have gone through the virus and not had severe symptoms. But what we are seeing in populations across the world is that there is a lot of loss of life in our fellow citizens of the world. When you look at that's coming from this group of people, and that's very important because we are a large family of world citizens and we need to care for everyone. It could be you and me. So what are the clinical manifestations? The typical symptoms of the SARS-CoV-2 infection and COVID-19 disease are dry cough, fatigue, fever, shortness of breath, gastrointestinal symptoms, diarrhea and vomiting, and what has now come to light in many reports is the anosmia or loss of smell and eugesia or loss of taste. And these are sometimes seen in early presentations of the virus, and now there's a lot of effort to see if these could be predictors of virus, especially for the ones that present with milder disease. Atypical symptoms are sore throat, severe headache, confusion, and muscle pain. And severe complications are respiratory distress syndrome, shock, and arrhythmias. The case fatality percentage, which is reported across the world, now the latest figures seem to show about 0.5% to 14.5%. So this is a lot of variation is there in terms of the case fatality percentage as to how many human lives will be lost after the presentation of the disease has been diagnosed in the people. So as of last night, the COVID-19 figures across the world shows that we are about 8.7 million people have been affected by this virus globally. And the numbers continue to rise, and that's the current slope of the number of people that are infected with this virus. When you break that slope down a little bit, and all these are coming from the data compiled by the Johns Hopkins University, and I'm sure that you have seen these figures before, but let's just recapitulate that when you look at the spread of the virus and how many people are affected, you can see that that's the number of people that is still rising. When you look at the number of people reported on daily cases across the globe, you see that when you go from March and you go into later on into April, so it started in March being reported across the globe, and then this is a steady rise. And there are spikes here and there. So like yesterday was a spike compared to the previous data that was available. So there is an increase in the number of people that are being affected by this virus across the globe. When you look at COVID-19 in our motherland, and you look at the data coming from India and as reported by Johns Hopkins University, you see that there is a very steep rise in the virus. So we didn't start out in March where the rest of the world were, and we had some good results and a lot of bonhomie about it, a lot of discussions at the time, and you've all participated in those, lots of messages across social media that maybe we'll have a much milder presentation, but that was not unfortunately the case. We have a very large population of 1.4 billion people approximately. So as expected, the virus has spread and it is causing a lot of havoc. So we are now at 4 lakhs or 400,000 people have been infected and diagnosed with this virus. There obviously, there's going to be more people that are not diagnosed as yet, and many people that are going to be asymptomatic, as you know. So the number of people will be actually higher than that, as is to be expected from these data. When you look at the number of people that are being reported on a daily basis, you can see, as Dr. Agarwal was also pointing out, that you see these numbers are steadily on the rise across the nation. So this is data from India as reported until a few hours ago. every country will have a different exposure and a different pattern of the disease and how it plays out in its population. So this is data from Canada using the same data reporting from the Johns Hopkins University site. And this is again from a few hours ago. But when you look at the most current data that was available on their site, you can see that it's starting to flatten out to a great extent. And when you look, so this is the total number of people that have gotten a positive diagnosis. When you look at the number of positive diagnosis on a daily basis, you can see that there is a significant downward trend. So if you were to look at that as a peak, so we've gone through that kind of peak in Canada, and we are probably hopeful to see that it is diminishing, and therefore life is starting to be able to go back to take charge of things that need to be taken charge of. And this is what we would hope happens across the world, and we hope that it sustains. So I would love to see that happen in South Asia as well, that this is the kind of pattern that we were seeing. But we don't see that yet, and therefore we have to take everything in due precaution. So this is just to tell you that there is a lot of variation in the presence of the virus and how it is spreading in different communities, in different populations, different countries across the globe. Some things which are important to look at, and this data is more readily available from Canada, so I just look into that, when you look at different age groups, so you see that people, as I said earlier, can be of any age that can be exposed to the virus and develop COVID-19. But there are some population groups which will be much more greater at risk. So when you look at these green bars are actually the people that have lost their lives. Look at the green bars. They are predominantly in the much older age group. So we owe a lot to our responsibilities. We owe a lot to the people that have built the world around us. And therefore it is very important that we care for trying to minimize this big green bar should be brought down as far as possible. We've seen that across the world. In Canada, the most, as I said, this graph shows Canadian numbers, but we had the greatest loss of life was in the old age homes, people that were on dependent care, and they were the ones that have paid the price of this virus, and it spread and led to loss of life. We've seen the ones that needed admission to the ICUs were in this group 40 to 50 and then 60 to 79. Not enough admissions in the older age group beyond 80 because they lost their lives in the process. To some extent, that was one explanation. But the virus can cause disease in pretty much all age groups, but some people that are more at risk will suffer greater consequences of it. And it is our responsibility to protect those individuals as we go along. Does the virus spread easily if it's on surfaces? This is a very controversial topic, but I thought this discussion would be completely incomplete if I didn't bring it up. So this one paper that has caused a lot of thought around it is from Van Dorman's letter to the editor in the New England Journal of Medicine back in March. And this showed that the virus can remain alive in aerosols and on certain other media for a number of hours or sometimes up to days. This is important to remember because a lot of things that we do on a daily basis will involve these structures. So the question about virus spreading through fomites is important when you look at these data. So in aerosols, in an experimental condition created in a nebulizer chamber using the standard technology that is used to check the aerosols experimentation. So it's a drum, and then there are three jets that lead to the creation of an artificial aerosol, and then they invested this virus on a typical load that would occur from respiratory infection. And they saw that, okay, if you had a person with a virus, it's in that nebulizer chamber. How long does it stay when you expose that virus to different media? So one, in terms of the aerosols, it was thriving for about 3 hours. So this is not a drained aerosol. This is just an aerosol in that chamber itself. Then you look at if it stayed alive on copper, a few hours, cardboard, about 24 hours. And these data are, this is from one group. There have been other reports from Hong Kong that also ran some experiments that was included in articles in the Lancet. But this is to give an idea that the virus can stay alive on many surfaces, and therefore we are responsible to maintain the disinfection of those surfaces as we go along. The great controversy that generates from this, and that paper is at the heart of that controversy, is what we do very regularly in dentistry, which is aerosols. So we use high-speed handpiece at times, and we will use a high ultrasonic scaler, for instance. So these generate a lot of that aerosol. And aerosol and splatter are two important things that we must understand when we look at potential of spread of infection. This is not just relevant to SARS-CoV-2. It's, of course, it's come center stage now, but it's relevant to dentistry performed on an everyday basis for any kind of infection spread. So splatter is considered to be for particles that are beyond 50 microns. Anything less than 50 microns is considered to be aerosol. It's a suspension of these particles and other pathogens within that mist or cloud that is created from air and water that is present as part of these equipments that is used. So you would probably think, and I won't go too much into this detail at this point, but you might want to say that, okay, so dentists have been exposed to this on a regular basis, so we must be, paying the price for it dearly in our own settings and losing a lot of health and life, perhaps. So the Office of National Statistics in the United Kingdom in May had released this data that showed that based on the occupational exposure, dental staff were actually very, very high up. So, and you would have seen these figures show up on social media and many other places that dentists are the greatest at risk, and that is quite true. We are closest proximity to the active region of that potential virus spread because we're right next to the mouth and nose. But then does that mean that we have shown any degree of sustained amount of disease or loss of health or loss of life? So Dr. Howe, who's a public health dentist, and he reported that he looked back into 10 years of data in the United Kingdom, and he looked at respiratory infections related with the proximity to the condition, and he looked at different professions. So people that actually had respiratory disease and had morbidities related to that were actually not dentists. They were not medical and dental practitioners who otherwise were very close to the so to speak, the area of the potential spread of the disease, but they were actually not the ones that were the most severely affected. When you look at medical practitioners, dental practitioners, they were actually lower down. And what that meant was that these people probably in their day-to-day activities are getting the virus from social aspects, handshaking, other things, but because of the fact that they are not using enough protection. But dentists and medical practitioners, we have over the decades been more exposed to personal protective equipment and other things. So we have now developed strategies quite well to prevent the spread of the virus on a local setting by taking due regard and precautions of doing that. It's important to say that our population that we treat is going to be affected in many ways. If we have a tendency to be concerned about a lot of this scare that is happening, our patients are going to be in the similar situation and perhaps even more. So there were some studies on the SARS, and that showed that there was an impact of the SARS epidemic back in the 2000s, where the population was quite seriously concerned about potential spread from the dental operatories. The potential spread also raises several ethical questions because we as a practitioner are responsible for the care of our patients, but who do we bring in? Who do we treat? There's going to be significant loss of business. We know that there are certain populations that are greater at risk for the virus, but they are at greater risk of dental disease and other things. How long can we put them off from treatment? How long can we not take on our primary role that we have taken as a profession to care for these individuals? So these are very important considerations when we look at the evolving scenario. The perceived vulnerability to the coronavirus infection, that is a concern that rises in dentists as well as in patients, and this is increasingly be reported. When you look at orthodontic data, so now studies are coming out that have shown that when you look at patients that have had ortho or that were in treatment, like I said earlier, and Dr. Gupta have also mentioned, millions of people across the globe were in orthodontic treatment when the virus current pandemic hit, and a lot of closures happened across the globe. So when you look at some samples, this is a very small study, although it looks big numbers, but very small study compared to millions of people. But it shows that people are affected by anxiety related to the fact of the disease, but not a lot of people that are actually going back to treatment are less anxious about the disease, but more anxious about perhaps that their treatment is now being prolonged. So it reflects variations in human perception of what's going on and what their concerns are, that Now the treatment is going to be much longer. Will that be more exposing them to more virus, and other concerns are there as well. Then we are also responsible for moral decision making. We have a limited supply of PPE, and we'll discuss a little bit about that. But how do we invest it properly? And we are responsible for taking care of our patients. So are we going to put ourselves and our staff and our patients at risk of doing treatment in an uncontrolled and unprotected way? Or are we going to be proactive about this, mindful, and approach this in a pragmatic way, using what information is available by synthesizing the data, discussing it, reading enough about it, and attending sessions like this one, if it's giving you proper and correct information, and things like that. So we as orthodontists do this on a regular basis. This is our day-to-day life. We treat patients who have a small lower jaw, perhaps, that need to correct the mandibular retrognathia and bring it forward and get a nice class 1 occlusion with a beautiful smile and set of teeth, or people with a whole bunch of crowding that need to improve their so-called oral health related quality of life. People that are born with craniofacial, orofacial congenital defects such as cleft lip and palate, or we were treating patients that have much more severe malocclusions, a very small lower jaw anterior open bites, and orthodontic treatment can make a huge impact in all these presentations of malocclusion, people with an commonly known as crossbite and severe retrusion of the maxilla compared to the mandible, and we involve surgical orthodontic treatment. So all these people have been affected when their primary long-term treatment, orthodontics is not a single sitting treatment, it goes across for many months and many years, depending upon the severity, etc. So it's important to remember that all these people now suddenly are in limbo when there's been shutdowns across the globe, and they are going to have to be cared for, and we need to start to think about that. So we published this paper. I had the good fortune to work with a really good group of team members that were my co-authors. Yona Vanders-Lewis, Anuraj Kochar, Dr. Agarwal mentioned this young man who's a really good orthodontist from Delhi who's collaborating, Dr. Basin, Dr. Muhammad Nur Abdullah. So all these orthodontists or dental students participated in this paper. And this paper is the banner paper. Currently, it's the banner paper on the Angle Orthodontist website. One of the most widely read papers there as well, which is to be expected because the world is looking at how to decrease the spread of the virus in our orthodontic settings. So we thought we wanted to give a synthesis of the literature and present it to all our colleagues and orthodontic community across the globe to try and see if some of that data can be used to improve the outcomes and to protect people all across the globe on this pandemic. When you look at the virus, how does it spread? So the individual can spread the virus many ways. We talked about aerosol and droplets. We looked at if patient is coming in contact with several operatory instruments, and therefore that's an indirect contact that can spread to staff and patients, or it can be a direct contact spreading to staff and patients again. Patient may have touched doorknobs, several parts of the operatories or clinics, and therefore there's fomites, and patient may transmit unwillingly or unwittingly to other people that may be in the same facility. So when we are responsible for that facility, we need to consider all of these ways of potential transmission, and we need to control for that. The National Institute of Occupational and Safety and Health back in 2015 gave this very nice figure that shows the hierarchy of controls. And this shows that the most effective way to control it is elimination, which means that if you don't have a patient that is having the virus and with whatever degree of viral load or a load that can cause infectivity. So if you don't have that person in there, so you eliminate the potential of virus spread, that is the most effective. It's not surprising to understand. You physically remove the hazard, the most effective. As you go along, different levels or different strata of the controlling of spread of infection, what is actually known is that the least effective is the personal protective equipment because it's limited in numbers, limited supplies. Patient can transmit in several other ways, not just that procedure itself. So a lot of things are there, that there are different hierarchies of controls, and we must look at all of them. These are looked up in the CDC website, so I would encourage you to read about that as you plan to work in your own settings and see how they all apply to you, because some of these will actually form the framework of what we recommend in the contingency management of orthodontic patients during the pandemic. So what we reported in that paper that I described to you earlier was that orthodontic contingency management should be founded on effective communication and triage. We should adhere to guidelines and advisories that are issued by the federal, state, and local health regulatory authorities. We should have a system of broadcasting communication to all our patients, provide phone and electronic access to the doctor for patient to be able to contact in case of emergencies, give remote advice on phone or video call or email where possible, provide only emergency in-person treatment when it is absolutely indicated and if the local health regulatory bodies have allowed that to happen. And if you have enough PPE and are able to follow strict infection prevention and control protocol. So in an acute phase of the pandemic, it's important to follow these in a very strict manner. That's our view. This is what we put under our signatures in that paper that is published. We recommend that we should pre-screen COVID patients, pre-screen for COVID in all patients that need to be seen, and provide health questionnaire, informed consent. And I'm going to show you examples of how this is actually being done. Patients should then wait in their vehicle or in a safe point until they're actually called into the operatories. We should minimize the patient's entry. Mostly it should be just the patient, or if the patient is a minor than one person. Entry should be, in an acute phase of pandemic, should be with a thermal check at the point of entry into the main clinic. There should be no waiting area seating or to have a sufficient spread between the seating area so that it decreases the chances of human-to-human spread. Remember that fewer people in there, that's one way of using the hierarchical management, where you're eliminating potential of a person that is an asymptomatic carrier by not bringing that person in. So you're also able to prevent that person from touching so many surfaces and causing fomite transmission as well. Pre-procedural mouth rinses are still quite debatable. There's not enough evidence that actually shows that they are helpful. They taste awful. I have tasted it myself. I've used 1% hydrogen peroxide. It doesn't taste too badly when you first put it in, but as it lingers on in your mouth, it actually has it has a weird taste to it, and you start to feel quite uneasy. So don't necessarily need to put your patients through it, but it is still recommended in many ways of thought that if you want to use a pre-procedural mouth rinse to decrease the viral transmission, some studies have indicated that it might be useful, and oftentimes there are opinion papers. When you're going through an acute phase of the pandemic, and we have gone through that, as I showed you, Canada numbers have changed, so our guidelines have changed in this country as well. But when you're going through an acute phase of the pandemic, only emergency treatment or urgent treatment was allowed to be performed. And this is the case that is in India and in many South Asian countries or other countries where the pandemic is quite acute at this point. And then it should be done with caution, minimizing the time of exposure. We should ensure we have proper PPE, strict IPAC protocol, avoid where possible aerosol generating procedures, and people that are known to be COVID-19 positive or suspected, they should be more appropriately seen in a hospital where there are negative pressure rooms or airborne infection isolation rooms that are available to handle those cases. It's very important that people do distancing and hand washing or alcohol-based hand rub, because the virus, the sheath of the virus is dissolved in alcohol or in soap. So that's one way of reducing the spread of the virus, by actually disintegrating the virus. So that's why hand washing is a very important critical step. Do it frequently, have the patients do it frequently, and I'll show you how we are following that as well. Rigorous disinfection following the completion of the emergency procedure. Any appliance parts that were cut, removed, should be treated as highly infected medical equipment and disposed of as a medical hazard. Use bleach or sodium hypochlorite at slightly higher concentrations. Ethanol can also use for small surfaces if it's in the concentration between 62% to 95%, because as I said earlier, the alcohol will disintegrate the virus by causing damage to its envelope. Hydrogen peroxide vaporizer Some of these things have been talked about for post-procedure decontamination, but it's not well-founded in the literature. Water lines that have been used should be adequately purged to prevent backflow, and sterilize the used instruments immediately, and dispose all exposed and unused disposables that were in the operatory as quickly as possible as a biomedical hazard. It's very important to follow this, because the virus, as we talked about from that limited data that I shared with you, can survive on surfaces for a long period of time. So if you've used the instruments, they should be sterilized quickly. The whole operatory should be cleaned. There should be minimal other things in the operatory when the patient is being treated. What really constitutes an emergency? There are some things that we have to see, and those are patients with orofacial trauma, cellulitis. If there's other significant infection, especially if the patient's airway is compromised, prolonged bleeding, or pain that cannot be managed by over-the-counter medications. Then there is urgent care, where there are several. There's a whole list of urgent care, and I'm just describing to you what our association or the regulatory body here in Ontario published, but Indian Dental Association has published this. ICMR, I think, has also published this. So you have the list of what is constituted an emergency in India as defined by the regulatory bodies there. So you should follow that. What is non-essential care should be deferred. So the principle to follow is emergency first, followed by urgent, and then finally, when things have taken good shape and things are in good control, to go into the non-essential care. Heroics is something which is often, we all want to take part in that, but there is a serious risk with that when it deals with the lives of people. So if it is something that is really non-essential and we can put it off, we should be pragmatic, we should be humble, and we should respect our fellow citizens and perhaps defer that for a later time point. Our guidelines have changed in Ontario because now our numbers are very low, and therefore non-essential and routine care is being returned to dental practices in June. But there was one recommendation from our regulatory body, which was back in 22nd of May, which is very relevant. So I've still kept that for this lecture to discuss with you. Depending upon what stage of the virus pandemic the individual region is, what they said then was you should define yourselves as either stage 1, stage 2, or stage 3. Stage 1 being highest level of community transmission, and stage 2 as the community transmission is declining, and then stage 3 when the community transmission has been significantly mitigated. So this is important to remember, that in stage 1 or the acute phase, you want to do as much of emergency only in person. Otherwise, try to focus as much on the remote management of the emergencies. And as the community transmission declines, then you can proceed on in a safe manner, taking due regard to precautions, and knowing that that hierarchy of prevention of disease transmission. Following that, you provide treatment to your patients. So in a stage where things are under lockdown, patients can be trained, and some of these pictures that I'm going to show you very quickly have been from patients that either were sent on phone or when they came to our practice after things opened up, then we had a chance to illustrate some of the things that they were doing. So this is just somebody with a poking wire or a poking power arm of a bracket. So using orthodontic wax, that can be just, this is the simplest one, just roll a little bit of wax and the patient can use it. Another frequently reported problem during this last 3 months has been people coming in with poking ligatures, and that's causing some problem because of the lip rubbing against that or cheek rubbing against that. So we advise them to use a pencil, and the eraser can be used to push against that and tuck that ligature in. So this has worked very, very effectively for a lot of patients. Then another frequent thing that we noticed in many patients over these last 3 months was breakages. So patients have had breakages at home, tube, they have been chewing on things, not being seen for their appointments, and the wire has broken. So patients can be encouraged to first safeguard putting a cotton roll or a cotton gauze, which they can get from the pharmacist, or use any wisp of cotton, protect that the cut end of the wire will not fly in. Then use a nail clipper of suitable strength that will be able to cut wires. And then using a household tweezer, they can retract the cut end of the wire and take it out, so that they are now more comfortable till the time that they can come in and be seen in the clinical setting when things have improved. Another thing that we commonly see is broken elastic ligatures, which is not a big deal. but for some patients it could be leading to some spaces that have opened up, etc., or broken brackets. And broken brackets is something that the patient cannot do anything about on their own, but this can sometimes be irritant, especially if it flips or turns inside out. So when a person has an inside out bracket or it has flipped over, what you can advise the patient, so we took some of these pictures to advise patients, and they can with their own finger just push that flipped bracket to the one side. Then using any household instrument, they can flip it, so that unflip it so that it's in its usual position, and then bring it back to its position against the tooth. Slowly use that tweezer to remove the ligature or the elastomeric ligature. They can cut it out as well if they would like, and then just retract the bracket. If the bracket doesn't come out easily by doing that, they can use whatever, it could be even a pencil end, and they can just push that back again into that embrasure space, because the space over here is wider than against where the bracket sits next to the tooth. And once it has come into that interproximal space there, they can flip it out and they can just take it out. So this has been quite effective on some patients that needed to have a bracket removed. Some appliances, like a forceps appliance is here, and that can sometimes come loose if the patient opens too wide or plays with it too much. So we have prepared these. This wasn't only for the pandemic, but we had already prepared this, and this can be shared with patients of how to put their forceps back together. So here's the upper member of the forceps, and there's the plunger, and we just guide the patient that they can hold it. They'll need 2 hands, so they can do it by themselves. They hold it in 2 hands and they just cut that. Some things will need the help from a second person, like the cutting of the wire. This will have to have their parent or somebody who is at home that can help them. And this person must always be gloved, because we don't know, this person could be an asymptomatic carrier or the patient could be an asymptomatic carrier. So again, we have to encourage that whoever is going to work inside the mouth of the patient should be protecting for the transmission of the disease as well. And same goes over here, whoever is going to do this part to take that out for the patient should be protecting themselves and the patient in that process. This is something the patient can do by themselves, and in fact is more easily done by themselves. This is just to show what we standardly give out to patients. These are pictures from other patients that I've corresponded with, who sent them to me on my iPhone or through email, who had small problems when they were going through the acute phase of the pandemic, such as a tooth has erupted halfway and now contacting the labial bow, and therefore the patient sent the image, and we talked over the phone, gave them some advice, and they were able to use household pliers, move that out so that the tooth is allowed to continue to erupt. And then patients can take images using spoons at home, and then just take an iPhone or any Android phone can be used to take wonderful images and report back to the orthodontist so that we can look at what's going on and help the patient with remote advice. If a patient has an appliance that has dislodged, this would constitute an urgency that requires the patient to come in and be attended in person. But there are many other things, like a spring that could have come loose, and by giving advice on the phone, you can draw. This is what I've done. The patient sent me this picture, so I drew on the picture just an arrow showing that they can actually hold the spring and actually twirl that out and take the spring out at home without having to come in. This is when we were in a complete closed or shut down in the clinics, only attending to emergency, and this was not really an emergency the kind that I described to you earlier, so we were able to handle such emergencies at home rather than to risk the patient we brought into the practice at the time for handling that. Again, this is an overactive spring because of the long time that the clinics were closed, so this was handled by the parent at home who was using a nail clipper here again and cutting pieces of that overactive spring and taking it out, and they were able to do it quite effectively. When you're bringing patients back in, it's important to bring people back on a priority basis. So as I said, first the emergencies, then the urgent cases. I see a lot of patients with impacted teeth in my practice. So there are people that were in active stage of canine or other, this is a central incisor, it was impacted and being brought in. So these patients I have prioritized and brought them in earlier as compared to others who were in treatment, as we have now started to open for more routine care. Another thing that is being followed, at least what I'm trying to do, is to bring back patients in clusters more, which means if you have ahead of patients that are not siblings, so if you have a brother, sister, or more than 2 people in a family, you want to bring that family together versus bringing them out in spaced out time. So sometimes you would need to adjust for that. Again, that's following the principle of cluster spread. or reducing the spread by bringing in people which are already in one home cluster at home to be brought in, rather than multiple independent individuals. So this is not everything has a bad outcome necessarily. When you're going through a pandemic, there is a person that we were treating, and she has had some a missing molar, lost to caries. The treatment plan had involved taking out the rudimentary tooth and the deciduous tooth here. This was already a canine that had moved in. Then the pandemic hit when she was going through space closure, but she had a good 1725 stainless steel wire, and we had a gable bend, and we were moving this molar forward. And this is where she came in after the pandemic, and that all of that space is gone. It didn't happen in 3 months' time, but she was already in that process. But things have actually helped her out because of a long 3-month gap where no active, she didn't have any emergency. But when she came back, this was quite nicely kind of aligned, other than the fact that she had that one molar that had broken off, the tube had broken off, and that was the only emergency. But she wasn't brought in to handle that emergency during the pandemic because that could be easily attended to. And here, as I said, the tooth has actually moved in quite well on its own by the mechanics that were already in place, and with good degree of root parallelism as well during that time. So when we are bringing patients in, one of the contingency managements, what at least in my practice, what I've tried to follow is that collaborating with our front desk team, which took the lion's share of the work here, every single person that was in treatment was contacting. Like I said, we first sent out a broadcast message to all patients, and then individually, every single patient was contacted, described that the office is going to be closed for routine care, but we're open for any emergencies that they must report, give them our contact information, have their most current contact information available through their primary and secondary phone numbers, their email addresses, so that everybody is on board. And then we spoke with them, and then columns were made for follow-up appointments. So any further conversation that is held with the patient must be documented. And this is a part of the patient's record as well. We also noted what were the appointments that were held or were going to be held at the next visit, which have now been postponed for a future time point. So then a second list was also prepared and maintained throughout this time and continues to be done even as of now until we have gone through our entire list of all the patients, but a second list is being maintained, which lists all the emergencies, and that emergencies and what was done in terms of how it was handled. So the emergency was described, then some of them were posted, and then this kept changing because the lockdown kept on being extended on a 2-weekly basis and things like that. So these dates are less relevant, but the nature of the emergency was first described, the notes describe how it was handled, what discussion was held, and then follow-up, not just emergency, but also follow-up. And the follow-up actually gave a chance to do a little bit of contact tracing as well, because we were able to ask the questions as to how the patients were doing and in terms of their potential sickness. And none of the patients had actually fallen sick, but by having a healthcare provider, be it that we're not medical doctors associated with the care, but by the healthcare provider's office actually contacting patients, it helps to those patients that may otherwise not know or may need assistance because now somebody is actually following up with them. So we have a role to play in the community on that effect as well. So after we started to open again, when the province issued guidelines, we can start to open. Then here's my strategy of how we're doing it. We got that list of all the patients. Of course, we were looking at it on a daily basis every single day as to how we're handling them and following up with them as well. But then I classified all the patients into 2 broad categories. One was classified as yellow, which I said we will bring in first, and then the green ones, which can be scheduled on a more regular pattern. The yellow ones are the ones that will be classified as urgent care appointments. As we are bringing patients in, this is the workflow that we are following. Every person that comes in is actually going to complete a pre-appointment pandemic screening and consent form. This is all done on the computer by email or by cell phone, and then they can send it up. This is reviewed the night before by the triage team. Our front desk team is acting as a triage team that then corresponds with the doctor, discussing with me if there is any question that's concerning. And we decide as to who actually will come in. And if there's a person that seems to have presentations of the virus, or that is actually brought out, and that's one way to identify it early on in the screening. That's what our province is recommending, that you screen the patients for COVID positive or COVID negative. So this is where we do that screening. Then Every person that will enter the premises is going to complete that form. Patient comes in, waits in their car. And again, in the car is important rather than socializing on the street. So they will be in their car, available on phone. The office then texts them when they're exactly ready. When the operatory is ready for them to come in is when they're texted. Patient walks in, goes straight into the operatory, no contacts, and they just don't straight go in. They will come in and use precautions, which I will just show you. But they don't sit around. They will straight away go into the orthodontic operatory, be attended. And as they're coming in, patients are required to wear a face covering. They will first stop at the hand wash or alcohol-based hand rub station. A mask is provided to those people that don't bring a mask for themselves. The mask is worn by themselves throughout the time that they are going to be in the premises. The temperature, which is no longer required in our province at this point, but I will recommend that this should be done when things open up in India, that when people come into the operatory, you should take temperatures and bring in patients if they have less than 38 degrees or less than 100.4 degrees of Fahrenheit temperature. Only those people should be allowed to enter the premises. Then they come into the operatory, straight to the orthodontic operatory where they're being treated. And from then they are going to finish their treatment. They will take their mask out only for the procedure, put the mask back on once the procedure is done. And then they will exit the room and walk in a one-way street manner. So they go from one door, they walk around and they come back rather than going back and forth and potential for fomite spread from other people. So this one-way street is a good strategy that we've started to implement, and it's working out quite well. As they exit, they are actually escorted out by staff so that they don't linger on and potentially unknowingly cause spread of the virus. And then as they're exiting, they will again stop at the hand wash station or the alcohol-based hand rub station, and that's how they will exit. Any appointments to be booked for the next one will be made electronically or on the phone, but they will not stop and make the paper appointment or at the desk appointment. Although the desk exists with protection, but all these appointments are actually made outside and remotely by the patient. So the office where I work, the principal is Dr. Neil Gujjar, and he has kindly shared some of these things, which I'm able to share with you. This is the questionnaire that we are using. There's a service called Hushmail, which you could subscribe to, perhaps if you wanted to use that by yourself. But this is an example of the questionnaire that is being used. You can customize it to your own needs, but it lists all the features that are specific for COVID at this time known from the literature. The patients will figure that, they will fill all of this out. It is protected by encryption. And then this is reviewed, as I said, it is reviewed beforehand, before the patient actually is going to come into the clinic. When they come in, there are signs that are posted again that remind them for their symptoms. And then in fact, when they come in and they're on the phone, that all these questions are again asked to them before they actually are allowed to enter the premises. This is just me showing you our typical pattern coming in. That's the alcohol-based hand rub. And so there's a non-contact hand rub station. And after that is done, before I actually enter the physical premise, this is the second door. So the one door outside is the second door where my temperature is being taken by an assistant. Everybody is wearing the PPE at this point, and the patient itself is also wearing a level 1 mask, which anyone should be able to get, or whatever mask or high fashion mask they might be wearing outside. Fast staff are trained for proper installation or proper wearing of PPE, as well as how to don, as well as how to doff the PPE. So these are standard instructions. Every country has them available, and I'm not going to go into detail with them, but it's important that every team that is working should be very well conversant with these methods of how to put them on, when to put them on, how to remove them, when to remove them, how to take care of the PPE. PPE is a very broad term. N95 is a hot buzzword. It's the most difficult thing on the planet right now, perhaps, to get. But just to let you know that for those of you who may not have gone through the whole discussion and details about N95, N95 is a respirator that, it has great effectivity and about 95% effectivity in doing that. Several different companies will make it. It's important that when you say N95, it is a form-fitted N95 to your face. This is an example that back in March, this is at the hospital where they had form-fitted every single person that was going to work in the hospital to see which is the size that actually fits and which provider or which manufacturers which size of which manufacturer fits that person. So it's important to remember that we have to use an N95 which is form fitted to your face and functionally sealing off and not preventing particles to enter. And that test has to be done before buying a whole bulk of these N95 protectors and thinking that we're actually protected. If you don't have N95, the CDC, as of June 17, has also said that you can also use a level 3 surgical mask if you're going to use an N95. And where do N95 really come into place? If you're doing that aerosol generation procedure. It is not required for other procedures in general, but if you're doing an aerosol generation procedure, you would be benefited by reducing the chances of viral particles from being spread by using an N95. And if you don't have an N95, then they also say that you can use a level 3 mask with shielding on your face and other protective ways of preventing the spread of the virus. Here is an example. This is me seeing a patient. So I've got a double gowning. I've got gloves on top of the gown. I've got a face shield. I've got a level 3 surgical mask. Just to give you an example, that's for patients that we think that we want to be more protective on. So I'm using this sort of mechanism for that. If you notice the operatory behind, other than what really needs to be there is that computer and a tray where the individual instruments to be used for that patient are brought out, and these will go from here directly into the sterilizer. But the other things, it's not filled with any other paraphernalia of the office. So we're trying to reduce any excess instruments being left on the table that need to be covered or that could potentially act as fomites for transmission. In our operatory, in the office where I work, and as I said, this is courtesy from Dr. Gujjar, who owns the whole establishment, and he's a leading dentist in Canada and North America, former president of the AGD, and he has installed at this point one negative pressure room, and with possibilities of doing 2 more in the 13-op institutional setup that he's tried to create over the years. So this is just an example of that. If you notice that it went from red to green, that is about 5 seconds after the door was shut. So once the door was shut, within 5 seconds, the atmosphere within this operatory has gone from red to green, indicating that it is now a negative pressure room at that point. So if you have a patient who is COVID positive and you need a higher degree of protection, with you are doing a procedure that might lead to greater spread of the virus, such as a potential aerosol generating procedure, then it's important to have the equivalent of a negative pressure room be available to be more protective. And you should have the monitor placed within the operatory so that when the procedure is actually going to be done, you want to make sure that it is in the green zone. So let's say that the patient's in the chair and you are now ready to proceed on with the AGP and you're going into that, you want to make sure that you're seeing negative pressure at that time when it's being done. There are other things to consider when you've got air exchanges. So the current recommendation from both our regulatory bodies and really comes from the CDC is that if you have air exchange rates, if you have absolutely nothing, it's about considered to be 2 air changes per hour. But if you have set up by using HVAC consultant, if you have increased the air change rate within the operatories and you're up to about this figure here, about 15 to 20 air changes per minute, then in order to get 99.9% efficiency for aerosol or reduction of chances of spread, then the time that you would need to leave the operatory unused after the patient is completed is about 15 to 20 minutes. It's in fact, if you have done 20 air changes per hour, then after the patient is finished, the follow time, which is the term used for saying where there's no, the operator will not be used to let everything settle, is about 21 minutes at that point. Some simple things orthodontists should do is, again, to reduce the fomite transmission. So we usually give patients the luxury of choosing what colors they might want to use on their brackets to be tied to the wires. Of course, this is never a healthy practice, but certainly at the time of the pandemic, this should never be used. Nobody should be touching this, and it's easier for the assisting staff or the orthodontic practitioner to hold a little color palette, and then the patient should choose, and then you would go ahead and using what's necessary. So just the last thing I want to discuss is about testing. I know that, again, this discussion would be incomplete if I didn't even mention it, because some of you would have these thoughts in your mind. Okay, so what do you do about tests? Testing is quite a laborsome act. It's quite controversial and quite expensive. And there are many ways of the testing to be done. And this is from a paper that one of our co-authors, Dr. Kocher, who is also that author in the paper, that he discussed. And he published a number of papers in different journals on COVID-19, but this is one from his letter to the editor in the Oral Oncology. And he summarized the different types of tests that are available. Again, tests continue to be evolved, but the gold standard continues to remain as a nasopharyngeal swab, reverse transcriptase PCR test that's done. And that currently has a wait time of about 3 hours. Usually it's about 6 to 8 hours. There are several things to consider. But as the discussion evolves, some people will say, well, we're going to start testing our patients in point of care. Now, there are several ethical implications of that as well, but other than the cost factors, please remember that we are not really trained virologists. So we have to be careful about the ways that these highly technique sensitive tests are done. If the sample is taken in an inadequate manner, such as this is a nasopharyngeal swab being taken, if this is not harvesting proper amount of sample or inadequately done, then it can lead to a serious mistake in diagnosis, a positive patient to a negative patient, and there is a chance of spreading the virus in the clinical setting by a dentist. So those are my thoughts. I thought I'd put together and bring to the discussion. I hope that they have served to instigate or stimulate some thoughts from orthodontic aspect of COVID-19 management in our day-to-day lives. I would like to acknowledge a number of people that have helped me significantly in my own thoughts around this, and my co-authors on that paper, which is Yona Bandis-Lewis and Raj Kocher, Ritash Abhishek, Mohammed Nur Abdullah, but then also my colleagues, Dr. Gajjar, and our team members, Aisha, Hina, Karnel, Pooja, Shannon, Benjamin, Sukena, Purva, Patel, Sonia, Bushra, and Gina, and then my wife, Dr. Sagun, and my son, Shreyas, who have helped me integrate a lot of thoughts around this. And in many ways contributed to the discussion that we have had today. So with that, I want to thank you for your attention. And if you have any concerns or any thoughts, please don't hesitate to blast me on my email and let me know what things I may have stated wrongly. And of course, you can talk about that as well. But anything right I might have said is largely the result of my discussions or contributions made by these people that I have mentioned in my acknowledgements. Thank you very much. We can discuss as we go along. Thank you.
Thank you, Professor Suri, for sharing your wisdom with us. And Dr. S.P. Agarwal, are you there? Dr. Agarwal? Yeah.
Yeah, I'm here. Yeah, can you listen me now?
Yeah, sure, sir. Please.
Yes.
Right. Thank you very much, Dr. Suri. Such a elaborate thing. In fact, I was expecting it because this is eye-opener for us. Now, one thing I must add to it, that you are already in a flat curve now in Canada, whereas in our country, it is still rising. Acute stage is still rising. So there is a difference whether we should take up or not.
Yeah.
One point was very clear about you. What is emergency? What is urgent? And what we can do it now. Right? We had few questions coming up in between. So one by one we can ask you. Before that, I was seeing the presence of my colleague, Dr. O.P. Kharvanda, who is here. We acknowledge their presence, earlier head of the department, AIMS. Dr. Utreja's name I saw that, and Dr. Mathur. So one question which is there, now we are in an acute stage of pandemic, and there are cases that already have pandemic. When should we start it and how we can take it or we should not take it? That's the one question coming up, sir.
Thank you very much, Dr. Agarwal, and it's my honor again. Dr. Kharbanda is gracing the session, and he has been my examiner. So, in my times as a student, and I'm still a student, but when I was formerly a student in my orthodontic residency at PGI, Dr. Kharbanda was my examiner in PG1. So, very nice to have you here, sir. And of course, as I said, it's really an honor for me to speak when my teachers have been in there and in front of many astute and highly decorated individuals such as yourself, Dr. Gupta, and many other senior members. So I'll try to delve a little bit of thought on what you have said, and which is why I chose to kind of talk about the acute stage of the pandemic. I absolutely agree with you, sir. The bulk of the discussion that I tried to describe was focused on the acute phase, and that we must be very, very careful. We must not be heroic when it is going to be, one, not needed, and two, not at the expense of others and ourselves and our team members and our family. Many orthodontic patients, as you have seen from some of the data, are in the younger group. There will be more asymptomatic, but they may carry the virus back if they have picked it up. And they will take it to a family member that they will visit or be at home and make that person have very severe risk of the outcome of the virus. So therefore, it is very important for us as orthodontists to play our due part in that. We talk about national service. I think there is no greater national service we can do as clinicians in our own motherland at this time than to be protective of our fellow citizens. And therefore, we have to define, every person has to make this decision for themselves as to who to bring in, because we are ethically bound to be patient care as well of our patient. But we have to look at it as to what risks we are putting the patient, ourselves, our team, and therefore the community at large by taking care of the problems. So those problems that can be attended remotely should be attended remotely. Those problems that actually become emergencies or that will become an emergency very quickly are the ones that I think we should bring in, because it is also our responsibility. The clear emergencies, we have no choice in the matter. It is our primary responsibility to attend to them as a doctor, as under our oath, but taking due precautions and due regard for all the PPE aspects that we briefly discussed about. But then bringing the emergent, the cases that will likely become an emergency very quickly. So we have to take care of those. And when things become better, and we can only hope for things to become better. So that's why we start to think about, as Dr. Gupta said, or as you had pointed out, that when we are going to open, what should be our thoughts in that way? So that's why I try to discuss those aspects. Be prepared for when things are going to become better. Therefore, documentation and contacting and all that strategy is very important to develop at this point. So those are my thoughts, sir, on those aspects. Emergency first, then urgent, and then when things have become better for the country is when we go to routine. So.
Yeah, we have Dr. Kharbanda now. I think he is unmuted. We welcome you, Dr. Kharbanda. Your comment, sir.
Thank you. Yes. Can you hear me?
Yes, sir.
Am I audible? Yeah. First of all, I like to thank you, Dr. Sanjay, for wonderful.
Thank you, sir. It's a pleasure, really. Thank you.
Your experience also reflected here. About urgency and emergency, we had a lot of discussion here because I did a couple of webinars before IDA and Indian Orthodontic Society before. And what is important is that it is the orthodontist should decide that how emergent it is for him to bring in, because all the conditions cannot be listed or described. And I wish to tell you that remote orthodontics will work. And in my own niece case, other day, I asked them to send me the pictures because she has eaten peach and then she broke one tube and one bracket. and we could remotely through video explain her what to do to her mother, and everything was done to the perfection, actually, more or less. So that kind of things we will evolve. I think we will have to create a few videos of common procedures which can be shared to the patient. If this happens, you can do that. But with respect to the condition in India, and many people have raised this question: what is emergency? What is urgency? In dentistry, we do not use the word emergency very often, because we use emergency for those emergent situations which are life-threatening, and which include when you have conditions which are affecting your respiratory airway, or produce angina, or deep infections. But in orthodontic urgency, we have added to our list, because I made guidelines for ICMR and the Government of India with a group of course, which I was chairing. So in that, we put in continued aligner treatment. That means that if the patient was on aligner treatment already, and if only aligners need to be issued, then we could let it go, because it will not involve much of interaction, physical interactions, and this could be done remotely as well. So this was added to the list of procedures, which urgent procedures, continued aligner treatment. Nevertheless, at the moment, the studies which have come up, one study has just come up from AIMS, that how many times and how much far the droplets from speaking survive in the environment. And it is talking about 6 hours, which is quite disturbing, that if you are speaking loudly in an enclosed environment, your mouth droplets can be available in the environment. So even if you are not infected, but you may be a potential carrier. So the risk is high. And many people have just asked that, why not with PPE? Why not we can start? The people usually ask me this question. I said, life is too precious at the moment. If we are in acute phase, means we have to protect life first. So that is my answer.
Thank you, sir. I absolutely agree with that, everything you've said. And here as well, not going into too many nuances, but aligners and other things that patient can actually pick up without having to come into the office, that could be delivered. The other thing about you would have noticed that we are providing face masks to every person entering the office if they have not brought one by themselves. And that derives from that same concept that a person could be perhaps exhaling the virus. So any person within the premises should have a mask on at all the times. So thank you.
Yeah, that's right.
We got 2 questions in between. If a person is already going for COVID treatment, when the dental emergency, we can think about it. Already patient is going on COVID treatment. That is one thing. The second question was coming, how much should be the GSM for PPE? Because that is very controversial here, different times. If you can comment on these 2 points, sir.
Sir, the last question, if you could just clarify, how much should be the
GSM, size of this, thickness of the cloth?
Okay, sir.
Any idea?
Thank you. Sir, we are I'll answer the first question first, which was the sorry, I've just missed my train of thought. What
patient
was
is undergoing the COVID treatment, already is infected.
Thank you. Yes, so the COVID treatment, my view, and I may differ in that from many other colleagues, although even in our own setting, there are 2 lines of thought as to COVID patients who have tested COVID positive or that are considered to be at high risk, and patients that are not tested COVID positive and are screened to be not having COVID-19. My personal view is that persons with COVID-19 should be the ones that should be treated in hospitals where there are stringent controls of airborne infection isolation rooms, where there's enough PPE and less chance of a protocol being missed, which has not been hurriedly put together. And the reason I have that viewpoint is because The whole world is just coming to grips to understand how to do things. We weren't prepared to provide treatment for COVID positive patients in regular dental settings. So we are not becoming experts in 3 months' time. The hospitals are geared up. Their standard of protocol is much higher. To handle a COVID positive patient is safer to be done in a proper setting where the protocols from a long time are in place, where they will have less chance of slippage on any part. So this is my personal viewpoint. I may be differing in this slightly with what even our perhaps colleagues might say in the community where I am, in the dental professional community or our regulatory body, but I think it is safer for those individuals test positive to be handled in a professional setting where these things are maintained properly and being done very well. We have created that room in the practice where I work. That's only for protection. It is not that it is our intention to bring people in COVID-19 and start to treat them on a regular basis over there. That is for an emergency setting. If that happens, we are prepared to, we have gone several different steps ahead and try to be as protective for the patient in that manner. Again, overriding principle has been, we are not going to try to become the hero on somebody else's expense. So that's the guiding principle on that, at least in my viewpoint. The second aspect about what should be the thickness of the PPE, this we are following closely as to what is the recommendation from the CDC. Again, I think I have refrained from trying to become an overnight expert in looking at a lot of manufacturing details. There is a lot of entrepreneurship that is going on, a lot of industry. There's a lot of people that I know that have probably invested in dental markets and producing PPEs and other things as well, or in the medical PPE manufacturing industry. It's, I don't think we were experts on this 3 months ago, and we cannot become experts on this very, very quickly. So there are regulatory bodies that have looked into this very carefully. We follow the CDC's recommendation. Our own regulatory body interacts with Health Canada, and which interacts with CDC, and they formulate guidelines, and we follow those because that's their main job. They are the experts. I wouldn't want to become the expert and tell you that, okay, so many fiber thicknesses or so many millimeters of thickness is going to be protected.
Sir, one very important question.
Sir.
What is the life of N95 mask and the face shield? When should we change? Every patient, or when? What do you suggest?
Sir, we are using the N95. So we, as I said, we are using level 3 masks rather than N95 for the most procedures. I'm not doing a long procedure for debonding or a long aerosol generation procedure. In my own practice, the principle I have followed is, considering that we have only gotten back to work only recently, it's only 2 weeks since we started, or 3 weeks now, that we were approved in this province to undertake regular dental care. But even in that, we have not done any debondings. Any debondings that are happening for broken brackets and are limited in time of exposure for taking it off, and we are not removing them when it is not needed. And anything of that being done, I'm the one doing that rather than exposing our staff members to be on frontline. What the most recent data is also showing is that when you do an aerosol generation procedure, and this has been known even from many publications 10 years ago, is that the operator sitting on the right and the assisting staff sitting on the left of the patient, if you're a right-handed operator, will catch most of the splatter and most of the aerosol within a short distance. So that's the maximum amount will spread over there. But then there will be a suspension in the atmosphere that can last much longer. Dr. Karbanda talked about the recent study from AIMS as well. So, and more are coming out. Yesterday, there was a publication as well talking about aerosol and risks of that. So in terms of N95, the N95 is being used for a number of days at end in the United States in medical settings. My concern also from dentistry standpoint is if there is an overuse of PPE by dentists at large, for whatever reasons, this will diminish the PPE supply for life-saving reasons. So we need to ensure, we have been told here that preserve PPE. In fact, the first call that came was dentists were asked to donate their PPEs for the hospitals when the pandemic was in the acute stage. So we have to act very responsibly as to are we overusing PPEs for a dental procedure and perhaps risking our own brethren in our community by the fact that those PPEs are no longer available to the frontline medical workers, where they may have a much higher exposure of a life-threatening person with a great viral load that is coughing and is in ICU and likely to spread much greater as compared to a healthy person that does not really have the virus and is being treated with an overuse of PPE in the dental setting. So that is why it's very important that we are looking at where we as a community stand. If India is standing at the level of acute pandemic, we should follow all behaviors like be in an acute pandemic, your first question to me, which means that deal with the emergencies only in office if they need to be, everything managed as far as possible remotely, and then use a very careful, judicious amount of PPE rather than overuse it. So can a N95 mask be used for a number of days? Yes, and it can be re-sterilized as well after that as well.
Congratulations, Dr. Suri, for this point. What's happening in our country, there's so many videos are going around, and they say once you use PPE, or even they give PPE to the patient also. And what they say, once you use it, discard it, properly throw it, biomedical waste. What point you raised it, that we will be having the shortage for medical emergency. I'm really impressed by this, your answer. Once again, congratulations. If you permit me, I'll hand over the mic back to Dr. R.P. Gupta and Dr. Arpit sir. Take over. I'm very well there, sir.
Thank you very much, Dr. Agarwal. Thank you. It's an honor that you moderated this session, sir. Thank you.
If you permit, I can add a point about PPE, what is the protocol which has come here actually. There is a point about N95 mask. If it is okay, I can add here.
Yes, sir, please. Thank you.
Yeah, now what protocol they are following about N95 mask is that they issue 5 masks to one doctor. And these masks are kept in a brown envelope. You use the mask number 1 on the day for one, and after the use, at the end of the day, you keep that in brown envelope. Then you go for number 2, number 3. So it is expected that if the N95 mask, which has not been wet, if it is wet, it cannot be reused. If it is dry, then it can be used on 5th day. It can be reused. So every doctor is issued five brown envelopes and 5 masks. So that cycle they are using. If the procedure is going to generate some aerosol, then the recommendation they are saying that over the N95 mask, use a surgical mask, triple layer mask, and you discard the surgical mask and reuse the N95. I hope this point is helpful.
Yes, sir. Thank you for elaborating on that. That has been the guideline in CDC as well. They mentioned it, I think, a few months ago that in order to preserve PPE, which is also one of the important goals, then this is the procedure to be followed. And once it's soil, then of course it is violated. But if it's not soil, then it can be used, and it can now also there is data showing that it can be sterilized as well. But thank you very much for elaborating on that aspect as well. Thank you.
Yeah, thank you, Dr. Kharbanda. Thanks. Sir, Dr. R.P. Gupta, sir.
Okay, so many thanks to Professor Suri for sharing his wisdom, and thanks to Dr. S.P. Agarwal and Professor O.P. Kharbanda as well for joining in and adding up and sharing us their thoughts on these important aspects. So if there are maybe 1 or 2 more questions, we can still take them up if anybody is there. We don't want you going back with some questions in your mind. So if there is anything, we can still take it. And I'm just waiting maybe 10 seconds if anybody wants to add up.
One question, I got it. What is the period during which the virus is contagious? You mentioned from 0 to 14 days, but suppose it get tested on 7th day. We don't know before that. So our audience asked the contagious nature of the virus, sir.
Sir, there's a lot of unknown about this. It is, the chances are of making an error are greater than being able to pinpoint more closely. So the recommendation is that you wait till the person is shown to be negative and is is certified as has gone through the disease, has become negative as revealed by 2 tests, which are the most gold standard tests, done more than 2 days apart, have also spent at least 3 days with no fever without the support of medication, and then has also been at least afebrile for that amount of time and have not presented with symptoms for the 10 days from the time, and this varies. The number of days, sometimes they're saying 7, 10, this varies a little bit. So I would say that for those patients that have tested positive, they need to get that clearance, and that clearance, the gold standard for clearance to say convalesced is when you're showing 2 negative results. Otherwise, there's a chance that we are taking. And if somebody, we have had patients, I have treated patients of my own whose parents have had COVID. Now that we have been back in office for the last 3 weeks, we have started to see some patients come back, and some of them have described that they have had parents that have had COVID back in March, and now they are all recovered. We have had patients that have lost their loved ones to the disease as well. So there is a lot of tragedy as well that we are seeing, and I'm sure all of you probably have seen similar things or will see this as things proceed on and when you return to practices. But it's, I think, again, you have to have a clear certification by a medical colleague that will rely on the data from the test to say that this patient is now negative and is now safe to be, has now convalesced, is now safe to go back and attend their routine dental work. So we are following the CDC guidelines at this point.
Well, many thanks to you, sir. And I also acknowledge the presence of Dr. Anuraj Kochar, who is patiently answering few questions on the chat. So I appreciate his gesture. Dr. Anuraj Kochar, please. And with this, probably we are towards the end of today's session.
Arpit,
Yeah.
Arpit, I want to take 2 minutes.
Yeah, please, sure, sir. Please go ahead.
I want to welcome and acknowledge the presence of our past president, Dr. Chamna, Dr. Kharbanda of ICD, and Dr. Vijay Mathur from the AIMS, Dr. Kohli from Jabalpur, Dr. Rajiv from the Patna, and other fellows also. I am getting their names inside. And I want to talk a little about the ICD also. International College of Dentists is celebrating its 100th year this year. It was founded in 1920, now it is 220. It is the most oldest and honored society of the world. It has around 12,000 members in whole of the world, and India still having only 500 or something like that. And they can be inducted in fellowship only they are invited to apply for it. And then after receiving the applications, their particulars, biodata, etc., they are scrutinized by the peer group, and then they are only informed that they are eligible for the fellowship. It is headquartered in Michigan, and it was founded in 1920 in Japan, Tokyo. I request here some suitable persons who are above the age of 35 and must be an IDA member from the last 5 years can go to our website and download the form and can apply to they can send to any fellow whosoever is near to us. Thank you so much. Thank you, Arpit.
Thank you, sir. And now I call upon Dr. Ashish Gupta, who is the Vice President of IDA Chandigarh State Branch, to propose a vote of thanks.
Hello, can you hear me, Arpit?
Yes, sir, it's there, but it's a little low. If you can hold your mic a little closer. Yeah.
Hello, can you hear me now?
Yeah, perfect, sir. Please go ahead.
Thank you. A very good evening to all of you. It is my great privilege to propose a vote of thanks for today's webinar. On behalf of the organizing committee, I extend my heartfelt thanks to Dr. Sanjay Suri, Professor and Director of Graduate Orthodontist at Faculty of Dentistry, University of Toronto. Dr. Sanjay has very beautifully intimated the do's and don'ts in orthodontics to minimize the risk of COVID-19 transmission in clinical practice. I'm sure the valuable information provided shall help the dentist in a long way. Dr. Sanjay, thank you for sparing time from your busy schedule and enlightening us with your vast wisdom of knowledge. We look forward to hear from you more often. I also extend my gratitude to Dr. S.P. Agarwal of today's webinar's moderator. Sir, your inputs are really valuable. Thank you for taking out time from your busy schedule. I would also like to thank the viewers of this webinar, and special thanks to Dr. Channa, past President ICD International, Dr. S.P. Singh, Dr. Utreja, and Dr. O.P. Kharbanda. I take this opportunity to thank the organizers of the webinar, the IDA Chandigarh State Branch and ICD Section 6 for arranging these informative sessions. Surely the webinar series have improved our clinical efficiency, and the tips provided shall help the dentists in improving their dental practice and minimizing the risk of COVID-19 transmission. I request the organizers to continue in their endeavor for such brilliant continuing dental education programs. Thank you.
Many thanks, Dr. Ashish, and thanks to all again. And it's a humble request from my side to please share your feedbacks. There is a link which is being shared in the chat. You can very well click that link, and it won't take more than 30 seconds sending us your feedbacks. Your feedbacks are very dear to us, and they help us improving our future endeavors. And I also want to welcome you for the next webinar in session, which is on coming Thursday, that is 25th. And we will be talking about periodontology during COVID-19. And with this, we have come to an end of today's session. We had an overwhelming session today, and thanks to all the participants for taking out time and joining us. I am Dr. Arpit Gupta, the General Secretary of IDA Chandigarh State Branch, signing out. Thank you so much.
Thank you very much, everyone. God bless you and wish you all the very best. Thank you.
Thank you, everyone. Thanks, sir. Thanks.